Good morning and namaste. It's a delight to be here with you, and thank you all for everything you do. Dr. Gerald J. Deep, thank you, and Medvarsity. Dr. Sangeeta Reddy and Apollo, thank you for your leadership and your excellency. Thank you for your hospitality in your wonderful country. This is an amazing time, and I am privileged to be here among so many inspiring leaders. The Apollo team and the work that Dr. Reddy and her family are doing is really quite remarkable. It's been said that the future is here, it's just not evenly distributed. And we have two jobs. One job, of course, is to create that future, and the other job is to share that so that we can raise health for everyone around the globe. What an incredible opportunity we have. So, Joint Commission International has the privilege of operating today in over 86 countries, and our privilege is really to be the receptacle as a learning laboratory to see the best of what's going on in terms of supporting healthcare and in support of a vision that all people always experience the safest, highest quality, best value healthcare across all settings. And I think there's no time more than now where that vision is more important. Our work is really meant to enhance safety, quality, and reduce risk, empower individuals to support better care, and in that process, improve patient outcomes. When you have the privilege of working around the globe, you see some universals. And one truth is that healthcare is brutally complex. It's complex in so many dimensions, and in my country, most recently, it's very complex politically. It means that healthcare organizations are, struggling. We have workforce shortages. Healthcare is less affordable than it should be. Finding services, behavioral health, particularly difficult, and there is a burden of regulation. At the same time, healthcare workers themselves are struggling. Violence to healthcare workers occurs in the United States, has increased 200% since before COVID. And patients still struggle getting the highest quality care that could be available, the safest care, the best experience of care, access, equity, and affordability. We have an opportunity for a step change. AI is no less than the defining technology for the century. And so really the question is, how do we take signals that we know exist that may be unclear and make those signals through the use of technologies like AI as absolutely clear as possible? And the headlines across the United States every day and internationally is about not only AI's uses in so many fields, but specifically to empower improvements in the delivery of health service for safer, more effective, and frankly, more compassionate health outcomes. It affects every realm of healthcare, from the biological and life sciences to the structure of proteins, where we're finding in 6 months, 6,000 binding sites for new pharmaceuticals, which took years in the past. The binding site for the HIV antiviral therapy took 2 years to elucidate. It was ultimately accelerated to 2 weeks with crowdsourcing by gamification. And following generative large language models, the protein folding structure, the quaternary structure of 6,000 binding sites were elucidated in just 6 months. By 2030, the global market for health AI will be nearly $200 billion, and you can see the use cases ranging from the biological sciences to things that we expect, like clinical decision support and the ambient awareness that helps take some of the burden out of the process of healthcare, as well as the operational improvement. But this poses a number of questions about how we use AI, how we pay for it, how we address liability. But what I'll focus in on today is the regulation of AI, because frankly, I live between two fears. The fear on the one hand that we won't have guardrails to prevent us from doing untoward, or prevent untoward outcomes from occurring, and a greater fear on the other side that we won't use AI, that will be stifled by overregulation, overreaching policy, that will keep us from achieving that step change in performance. And I mean step change in economic terms, something that fundamentally recalibrates the level of productivity and quality of a process. And on the left in the United States, we had a major misadventure when a large insurance company used an algorithm trained on a general data set that unfortunately didn't ameliorate racial bias, but amplified it. On the other hand, on the other side, my team actually received the Eisenberg Award for a sepsis algorithm that saved thousands of lives. I'm going to show you that. But in the middle, I want to just frame the discussion of the guardrails going over turbulent waters with a paper by Andrew Arbach from the University of California at San Francisco that showed that in the United States, 23% of patients who die or deteriorate in hospital do so because of a missed or a misdiagnosis. And as I said, healthcare is brutally complex, and let's look at the tools. Now, the first thing I think is so important is that we tend to refer to AI as one thing, but it's really not. I like the nosology that Karen DeSalvo and Michael Howell put together that talks about 3 epochs of AI, where epoch 1 is something we've been doing for 50 years. We've been using probabilistic logic to help us make better decisions. If the patient is hypertensive, then treat with an antihypertensive drug. AI 2.0 is really, in their terminology, deep learning, where the use case on which the system is trained is the same use case in which it's used. You train a system to read 100 million mammograms, and then you apply it to mammography. And already we see that the performance is better than humans, particularly low-volume radiographers. But the use case for training and the use case for application are one and the same. Where it gets more interesting is the use case where it's not the same. And that's what happened with that payer algorithm for heart failure, is that the training data included both good knowledge as well as bad knowledge or bad input. And that led to a bad outcome. David Blumenthal refers to this as pregenerative and generative, and that's the sort of separation that we believe will define the policy, the regulatory approach in the United States. So I want to walk up this diagnostic or this data hierarchy from descriptive to diagnostic to predictive to prescriptive to autonomous, but using an AI framing of that 1.0, 2.0, and 3.0 in 3 examples. And let's talk really about what the risk levels of these are. And Dr. Reddy set such a wonderful stage for talking about these use cases. She talked about operations as one potential example. So I was part of a large health system, 63,000 beds during the height of COVID, and we needed to improve our throughput. So this is actually patients admitted to the hospital, generally through the emergency department. This is nighttime when they split in 2 to OB or NICU and obstetrics, some other having a child. But we began to codify all of these data about patient throughput so we could predict the risk of admission of a patient in the emergency department, the risk of transfer to an ICU from a patient in general medical or surgical ward, the risk of discharge, home or otherwise, and begin to build throughput. How much risk really is that? Well, very little, because it improved throughput for patients who otherwise wouldn't have had opportunity. Let's take a second case. Imagine you're a patient and you've been told that you need a biopsy to rule out prostate cancer or breast cancer. Well, you get your biopsy. What's the hardest part then? It's waiting. Well, what if you had a small language model, a vocabulary that's robust but can differentiate nuances and contextualize and read fairly standardized pathological reports? Well, we put this into implementation in my previous health system pretty quickly. And when was the last time you heard about a 2,100% productivity improvement in healthcare? It was equivalent of 120 new cancer registrars, timelier care for patients, greater engagement, certainly for the patients, risk of missing a diagnosis was reduced, and better outcomes for time-sensitive cancers. But here's the really interesting part, is that it completely changed the role of the nurse navigator from 70% of her time being administrative to 70% of her time in direct clinical interaction with the patient, a much better use of a human resource. Now, one of my mentors is a guy named Bill Stead, and he taught me about the complexity in terms of facts. Now, at the turn of the 20th century in the United States, when phone numbers were established, they settled on 7 digits because psychologists had determined that humans can manage between 5 and 9 variables simultaneously. And so they took the intermediate. And I'm going to come back to that, but in the average ITU, there are about 1,000 new facts per hour and about 300 orders in effect. That's about 1,300 variables. How different are 7 from 1,300 variables? Well, you've probably already done the math on the number of combinations of 7. It's 7 times 6 times 5. Yes, it's 5,040. What about 1,300 factorial? Is it a million? Is it a billion? Is it 1 trillion? There are some people who are saying, John, you are leading us down the garden path. It is nowhere close. It is the head-spinning number of 3.16 times 10 to the 3,485th power. How big is that? Is that as big as the number of grains of sand on the planet? Not even close. That number of grains on this planet is a fraction of a fraction of a fraction. That number is so large, it's likely larger than the number of particles thought to exist in the universe. I don't know about you. I'm a simple internist. 7 variables, yes. 1,300 factorial, quite difficult. So if you're this patient, not the average patient, this patient has 99 different drips, 29 different IVs. The number of data points coming in are even greater. This is sepsis in my own health system. This is a 24-hour clock, 0 to 23. And this is shift change, and the depth of the color represents the depth of detection of sepsis. So it's really clear from this study that sepsis occurs at shift change. Obviously, sepsis doesn't occur at shift change, but if you train a model through deep learning to look at both the features that we would regularly associate as well as things that we wouldn't necessarily think of in terms of patient demography and orders and labs, et cetera, then you see that sepsis really occurs on this schedule. Now, did you know that for every hour of delayed diagnosis in sepsis, mortality increases between 4 and 8%? So when you can move the clock back, you save lives. And by just detecting, and this gets to the ease model that Dr. Reddy showed, this was really explainable. This is before we went to predictive, just simply by showing clinicians those features. Patient has A, B, and C. Do you think it could be sepsis? That clock got moved back 6 hours with not only gold standard sensitivity, but even better specificity. And if you actually meant to predictive, you could move back. But just by detection, in the year that this was implemented, we got a step change, a 23% increase in detection of sepsis. And over 5 years, this system saved 8,000 lives. This is what 8,000 lives looks like for individuals who got to see in a new year, celebrate an anniversary, welcome a child or a grandchild, and this is what it means to learn and improve at speed and scale. Now, when we were doing these sorts of things, I felt uncomfortable because what were the rules about the use, the appropriate and safe use of data? What are patients' rights? Well, they want agency over the use of their data. They want freedom from bias and external verification of responsible use. Benefits, better care for the population, safer care for the individual. And so we partnered with a group in the US of health technologists like David Brailer, as well as privacy advocates and others, and these were the 6 criteria that we came up with: de-identification or privacy, data control, security, limits on use, transparency of the patient. But the really important part is the interplay of governance and verification of the algorithm. If we go back to the failure of that heart failure algorithm, there were 3 things that had to happen. 1, the algorithm had to work mathematically, had to be technically functional. 2, the algorithm had to have the right clinical evidence and had to have the appropriate domain expertise. And 3, there had to be clinical competency to understand the risk of bias and certainly to detect drift. And so the governance process is all about that. And when we go back then to thinking about how different countries, my own included, might regulate AI, let's be thoughtful about it. Let's not over-regulate what we've been doing for 50 years in probabilistic. And you look at the patient flow, which is really simply deep learning, machine learning, that's single use. Let's not over-regulate that. When you look at the sepsis prediction, let's not over-regulate that either because the use case is defined and it relates to the training data. When you get to language models that begin then to infer diagnoses or generate notes, maybe we need a little bit more scrutiny on those, but let's not foreclose the efficiencies that can be gained. We hosted a large summit in Washington. We had both the Republican and Democratic leaders in terms of health AI in the Senate and from the White House as well. Some of you, I'm sure, know Mickey Tripathi. Jay Obernolte actually chairs the appropriate committee in Congress and was a video games developer. Don Beyer is actually getting his master's in AI. And they were very interested in how AI would be regulated and very warm to the notion that AI is not one thing. So why a responsible use of AI framework? Well, let's go back to the opportunities we have. 23% of patients with a missed or misdiagnosis. And I always feel in good company when I quote the same person as Dr. Reddy. When you think about the fact that 23% of patients did experience a missed or a misdiagnosis, then I think Einstein was absolutely correct. The level of thinking we have done thus far creates problems that we cannot solve at the same level of thinking that created them. We have the opportunity for a new level of thinking, a level of thinking that's augmented by a technology that helps us wrestle those 3.14 times 10 to the 35th power of complexity. And all of us as health leaders, as policy leaders, as clinicians, as informaticists, bear the responsibility to support the implementation to make health safer, more effective, more efficient, more equitable, more accessible, more affordable, and more compassionate. Thank you very, very much for the opportunity to be with you. Namaste.
Thank you.